Welcome. I'd like to introduce you to the Empowering Patients Living with Epilepsy presentation, and we're going to focus on the importance of rescue treatment and emergency plans. I'm Dr. Brian Lundstrom, Assistant Professor of Neurology and Biophysics here in the Division of Epilepsy at Mayo Clinic.
And I'm Greg Cascino. I'm the Whitney McMillan Jr. Professor of Neuroscience and the Enterprise Director of Epilepsy at Mayo Clinic in Rochester, Minnesota. Oftentimes patients have been asked about this. In fact, they've not heard the term acute repetitive seizure cluster, and they may not have even had one. And I always use a story, which is a true story, that I had a evaluation of my home by my insurance company, and I was nixed for not having a fire extinguisher in my kitchen. My home insurance rates went up. I said, well, why? They said, because you could have a fire in your kitchen. It's the most common place in your house to have a fire. They said, you never know when you'll have an emergency, so you need a rescue plan with a fire extinguisher. And I've always thought this is kind of a nice analogy to seizure clusters. Occurs commonly. Patient may not have had previous episodes, but you need a rescue plan. You need an emergency plan to manage the patients. And I kind of like my insurance company. I need that fire extinguisher.
Every seizure I've always written down, every medication change I've written down, when we increase it, when we decrease it, when we have surgery, or when we, everything has been, I've tried to document her journey. We've kind of established our emergency plan using our rescue medication, and we use that when she clusters. And Christina, right now, she has probably, on a good month, she has maybe 30 to 40 tonic seizures a month, and then on a bad month maybe 90 to 100 a month probably, but 3 to 4 times a month she'll cluster with the tonic seizures, and it's at that time that we use her rescue meds.
I think it's really necessary to have a plan in place, and many times who's going to give the medication, whether it's intranasal or rectal. Patients not going to administer themselves if they're in seizure emergencies in many cases. So not only do you need the medicine, but you need the personnel in place, whether it's at a group home or in a person's home or at work. And so there's a certain amount of preparation on our part. But I think it's like the fire extinguisher. I've never had my fire in my kitchen, but you have to have a plan in place. You have to have the resources and the personnel, or else you're going to pay a price. That's kind of what the insurance company told me, and I think it's the same here. Except this is a life-threatening emergency, a little different than a fire in a home.
It's very clear that, as we both know from firsthand experience, that when patients have multiple seizures within a 24-hour period, what actually happens versus what we might think ideally happens don't always play out in the same way. Oftentimes there should be a plan in place, but it may not be clear to all the various parties, and so there's probably more effort that could be done to clarify the plan, whether you take the medication, how you take the medication, and when you take the medication can all be points of confusion. When you call the doctor's office and at what time you call the doctor's office and expect a response, all these things can be problematic sometimes. And of course, the goal is that we avoid seizure clusters as much as we can. We certainly want to avoid status epilepticus. And if possible, we all probably want to avoid visits to the emergency room if that can be done safely. A lot of these points really highlight the need to be a little bit proactive as best we can. One of the ways to be proactive is to have a seizure action plan. A lot of these factors that we've mentioned should be in that seizure action plan, such as what are the usual patterns of seizures and the triggers, what do the seizures look like, what should the care be that they receive for the seizures that they have, and what kind of rescue treatment should be administered. And, of course, when to call for extra help. All these things can be summarized and should ideally have been thought about and to some extent have the plan in place at all times.
I think anyone who's at risk should have the appropriate rescue medications available in-house, in their hand, not a pharmacy prescription down the street.
We've learned over time that after about 4 to 5 tonic seizures, she's going to keep on doing that. And the sooner we give the nasal spray, the sooner that she'll stop. The longer that we put it off, we know that the longer the chance of the seizure is going to last. We just kind of follow follow what we've been instructed to do in the past. And I always carry a nasal spray with me, now that we have that. And so we're always prepared.